the final part of the day actually hopefully will address that issue that you brought up, which is that we'd like to have a discussion with a couple of our afternoon presenters, Dr. Taylor, Jan, and Dr. Cohen. If you want to have a seat up here, and we can kind of generate some more questions and discussion about what the next steps of this project are going to be. Do you want to get the ball rolling a little bit? Do you want Wait, Mike. Jen. Jen. Right. Yeah. So this is a time you can direct questions to the experts at the table or any of the presenters from throughout the day.
Are there any remaining thoughts, comments? That you don't have to have a question, you can have a comment, or is this on? Can you hear me? Again, I just want to emphasize that there may be some confusion. Maybe it's not down. There may be some confusion about what this is about. As I pointed out, this is a kickoff conference to establish a dialogue, to hear some discussion about information, but what we want to move towards is development of a working set of guidelines that are consensus-based. Now, obviously, everybody has different opinions on the approach, and from zero tolerance to everybody should be on benzos, pretty much, or whatever, or it's just okay. Well, we want to do this revolving around, as much as possible, evidence-based practices, and again, the idea is to come up with a consensus. But keeping in mind, the goal is to maintain and retain patients in treatment. Discharging patients from treatment should be the last resort, and it should, in my personal opinion, there should be a series of interventions or steps that you take. Yes, there may be a circumstance where it is too dangerous to continue that patient in treatment in an opioid treatment program on methadone or buprenorphine because of their continued dysfunctional use of benzodiazepines, but that should be the last resort. And I think if we think of this, in terms of developing some guidelines on how to approach this, we can use this as a reference. And, the vast majority of patients will not be in that category. That'll be the rarity. So, and then we want to have some consensus on, well, how do you go about getting to that? At least some agreement. So, to start it off, question? We need a mic because we can't hear you. Okay.
I think there's been a considerable amount of energy generated today concerning these issues, and at least I can speak for myself. I'm thinking, so what is next going forward? Maybe not even a time definite, but sometime forward. When can we look forward to developing something that is a consensus, that is a written, that is some kind of gathering of the current and relevant information?
Can you speak?
I can say a few
words.
Oh, Dawn. I just want to say a few words about the method that we're going to be using in the next step of the process. Dr. Taylor mentioned it's a sort of a consensus panel. There's a process by which we will generate potential clinical guideline statements, and many of the presenters that you heard from today will be involved in a process where they will rate each of the statements on their appropriateness. And there's an analysis that happens sort of behind the scenes, and the product that comes from that is a set of clinical guidelines for the management of benzodiazepines in medication-assisted treatment. We hope to have that process completed in the next 6 to 8 months, I want to say, after, conservatively, the next 6 months following this conference today. So we're going to get started with that right away. We'll have a sort of a webinar process by which there will be a discussion among the panelists on each of the statements, on anywhere there was disagreement. And then we will consolidate all of that information and produce a product that will be a set of suggested clinical guidelines. And sure.
For Pennsylvania, or, I'm sorry, I didn't want to use the microphone. Is that for Pennsylvania, or published where? For who? Just,
Pardon me?
The
I'm sorry.
the guidelines are going to be published, like,
Roland will speak
Roland
to
can
that.
speak to that.
I'm usually big enough and loud enough, I don't need a microphone. So if you can't hear me, something else is going on. I need it anyway, right? Okay, well, maybe I'll break out into song. A couple of things. This has been a collaboration amongst a number of different entities. Philadelphia, in terms of CBH, the DVH, IDS, CCBH, Community Cares, the state has chimed in. We've had excellent support, also, and enthusiastic support from SAMHSA. What we're hoping to actually have this do is this seed, you are the seed. We are planting a seed, and this seed needs to grow from here and actually build consensus across the entire region and the state. This seed hopefully then becomes a document, a set of recommendations that we can then export to a larger community. But the idea is that this collaboration began a year ago, and has been actually building up steam and continuing to build up steam. For instance, the one good thing that came out of this conference right now has been information about the fact that there are other options than just struggling within your outpatient program with somebody who is misusing or struggling with benzodiazepines. So how do we begin to take that information and put it into some kind of an approach that can be exported throughout the entire region and the entire state? What we would like to have is a document that informs practice within the state of Pennsylvania, but also informs practice in any setting, because it's the spirit of what we're doing, as opposed to a letter of the law kind of thing. Is that for me? Your hands are raised. Well, that's part and parcel what begins today with this panel. I'm hoping that there are statements, and whether they're being, I think Dr. Taylor said it best, it's not just questions. There are statements that people have, there are reactions that people have to what they've heard today. And what I'm hoping to see happen is that part of the rest of this afternoon, we have the opportunity to share that information, and so we can feed it back to you, so you can then give us back your impressions on that. Yes, ma'am. In the back of your folder, there's a CD, and that CD has everything that was presented. Well, I think Dr. Lindsay had indicated that we were going to put as much information together as possible coming out of this. We were also going to come back to our panelists and get their feedback. We were going to rate, some of the recommendations, some of the ideas, some of the statements that have been made, and we were going to feed it back to, a larger group. So I don't know specifically how that's going to happen, or the process through which that's going to happen, but I think that's the process. Yes, ma'am.
Yeah, I think the idea of having a period for public comment is a recommend that I'm hearing from them.
Yeah,
That we
I
could,
think
you know,
that was a part of the
Yeah,
plan.
yeah,
Again,
it's part of the plan.
good. So I think, in fact, I think that we're going to put out more and more information as a result of this. This is really the springboard for what we're going to be doing and how we're going to be doing it. So in fact, this is organic. The reality is you guys are saying, if we need a website, you know, to go to and get information from and react to it, then we'll find a way to do that. Facebook, you know, MySpace.
I had a question for Dr. Taylor. You made reference to assessment of impairment. In my experience, that's difficult. Tools or standards or guidelines for assessing impairment in our clients?
Okay, again, it's not rocket science. I'm
not
talking
even
about
close.
I'm talking about the basics of a mental status evaluation. Looking at the patient's appearance, their behavior, evaluating, you know, their speech, their motor level, and so forth, how they walk. It's simple. You believe me, it's not, you know, like in medicine we have all these sophisticated tests. Yes, there's some people who recommend instruments, but I'm talking about a clinical assessment. And in many cases, it's so obvious that they're impaired based on their speech, their gait, their affect, pupils. It's simple clinical care. Need a mic. Speak. Is it on? I think once you start talking, it comes on. Yeah.
There was some magic way we could figure out, does this person look impaired because they were up all night, or do they look impaired because they were drinking heavily, because they were
True.
taking benzos? And one of the challenges I know I often say to my patients is, I'm not psychic and there is no way for me to tell. And I think the thing that we are constantly on the hunt for, and please correct me if I'm not interpreting this right, but is some magic, if there were some scale, the way we can test, horizontal nystagmus or nystagmus rather for the alcohol impaired patient, some way to tell, is it safe to medicate them? Are they looking impaired because they're tired versus?
Or like an EKG and the ST segment elevation. Oh, yeah, you're having a heart attack. No. Unfortunately, it's a clinical judgment. And personally, the more you do it, I think the better you get. I'm just saying we need to start doing it because in many cases, it's not done. And it revolves around, like I said, a mental status evaluation, an observation of the patient gait. One of the things that has been very good for me, it's a simple thing, is handwriting. You look at the patient's signature, and you can see it. If in their records, from previous time, you can see it. It's they can barely write. So I know there's a subtlety to it, but there are times when it's quite not as obvious. But many cases, it's overt. That's just my opinion. I do want to respond to the comment earlier about patients, the reports that we get from the pharmacy records who review, you see a prescription for a benzodiazepine, yet their urines are negative. And so the question I think is, well, how do you manage those patients with negative behaviors? Those who, are selling benzos in the clinic, maybe they have take-homes and so forth. And what should be the approach? And we'd appreciate some feedback in that sense. My approach in learning and dealing with this is that we need to do a better job in educating our patients. And what I'm talking about is we have an epidemic in this country of prescription drug abuse. And patients who get these prescriptions and sell their benzos, they won't outright and tell you, but you're suspicious that they're doing, are part of the problem. Because the studies show that the vast majority of people who get these drugs, they're getting them from prescribers, or they're getting them from their doctors who are, and patients may be selling them, or they're kept in the medicine cabinet and the kids are stealing them and so forth. So the point I'm making is, and it's time intensive in working with these patients to help them to understand that they're part of this problem of prescription drug abuse in this country if they're engaged in this behavior, and people are dying. People are actually dying from the pills that they get that they sell. Now, some patients are telling me that, because I have those records as well, that they are getting the prescription, but they are not taking them because they're on SSI or they have disability. And they have to get the prescription from the doctor, because if they don't take the prescription, then they'll lose their benefits. So it's a complex issue, but we should try and work with these patients as much as possible. It is time intensive, but we need to engage them and help them to see they're part of the problem, and we are, working towards a solution. Question in the back?
Currently, in the United States, I was not able to come up with one. Yeah, it was just one of those things that I was looking through, like, okay, I've never heard of one per se, but, are there any published? And I could not come up with one that was more recent. I mean, there were some very old ones related to just don't use them at all, that type of theory. But there isn't a whole lot. There isn't any set curriculum. And I think that that's why my comment is we need to develop a curriculum so that it's effective and so that it addresses all the issues, so that we can educate not only the patients and their families, but the people who prescribe, as well as the ones that are delivering the education, because we don't have consistency and in the information that we give.
That's a good idea. I like that.
Very good idea.
Oh,
I think I have the mic. Thanks. First of all, I'd like to thank Dr. Taylor and Roland Lamb for putting together a really high quality, really terrific program.
Thanks.
And I had some thoughts about guidelines, because in my experience, guidelines are a lot of words and not always very practical or useful. But I've heard a theme throughout the day that I think should be the underpinning for a set of guidelines, which is essentially recovery. Benzodiazepines, methadone, they're not. I often get patients come to me considering going on methadone, and I've heard all these terrible things about it, and what I say is methadone it's not good or bad. It's a tool.
Right.
It's what you do with it.
Right, that's correct.
That's going to make the difference. And we can help you use it in the right way, or you can use it as part of your addiction, or you can use it as part of your recovery. And that's really your choice, and I can't control that. I can help you with that, but that comes from you. And I think in a similar way, I think we have a consensus that benzodiazepine use should be very limited and careful in the medication-assisted treatment setting. But Dr. McNicholas, I think you thought I was disagreeing with you before. I actually agreed with where you're coming from. I just think it takes, we have to be very careful. It takes a certain degree of trust, and which is established over time, to trust a patient with a benzo prescription in an MAT setting. But I think to determine whether it's appropriate or not, and whether someone is being utilized correctly, what is the trajectory of this patient? Are they still on an addictive path? Are they self-destructive? Are they lying, deceptive? What is the quality of their relationships? Are they blocking and avoiding feelings? Or are they on a recovery path? Are they becoming more productive? Are they taking better care of themselves? Are they relating more honestly to us and to the treatment providers in their life, to their family, to the people in their lives? Are they doing the emotional work of recovery? And if benzodiazepines are an assist in that for a limited number of patients and they're not abusing them, then okay. And maybe some patients do need them the way patients need methadone. Obviously, it's fraught with all kinds of difficulties, but I think that should be the theme underlying our guidelines.
One over here.
Just act a little bit to Dr. Taylor, your question about, you know, okay, how do we deal with patients who are selling parts of their prescription or their whole prescription? And I guess my thought kind of all through today, which was an amazing, tremendous amount. I really appreciate all that went into not only putting this together, but all the presenters. And but one piece that I found missing is the larger policy context, because when we talk about prescription drug abuse and as it relates to benzos, is that we can put together clinical guidelines and we can try and even really get those clinical guidelines into actual practice through lots of monitoring and TA and technical assistance and curriculums. But until there's also some policy changes around benzos, and whether it's scheduling, looking at how they're scheduled, whether it's looking at, you know, other elements that have been put in place at the FDA level around opiates, I think that a lot of what we're going to be able to do is kind of outside of the rest of this bigger context. So I wonder if that's something that the panel is going to think about, or kind of that you all have thought about as you're thinking about the impact that a clinical guideline could have.
When you say policy, you're talking about, help me to understand a little bit, what policy you're talking, a clinic
so I'm
policy
talking about
or?
some of the larger kind of policies at how benzos are scheduled, for example. So benzos are scheduled, they're a Schedule 3. So is there a way to really looking at the population level impacts that we talked about early this morning, to, if you think about kind of, okay, well, so even if it's not all of the benzos, maybe it's Xanax, right? Is there, what benefit and what are the potential pros and cons of actually really thinking about, well, maybe we want to reschedule, or maybe there's a thought about rescheduling Xanax so that you actually can have more of the population level impacts as opposed to, you know, kind of just at the individual patient and provider level.
Comment. I think that's important, but I wouldn't know how to get a handle on that within some kind of guidelines, but would want that question addressed. What I'm myself most interested in at this point is developing, for want of another word, an infrastructure. Seeing enough OMTs in our area that are floundering around, not knowing what to do. A number of them not even having a peer support group, not having any idea of what real ROSC is and how you do that in a program. No idea about how, when you write a prescription, how much to really write. Right. Some standards around that. Because as always, when I ever lecture my counselors and my colleagues, I say, there's patients out there much more organized than we are. And we gotta, and we have met the enemy and they as us. And we've got something to do around just tightening our act up. And I'd like to start there, but make sure that it's broad enough that it's not just the medical. It's got to be the therapeutic and it's got to be the administrative.
No, I agree. And again, this is just a start. and part of a bigger picture, and rather than a policy on changing a schedule, I'd like to see a policy on more physician education about prescribing and communication amongst physicians and knowledge. Some of those records that we get, I see patients are getting 2 and 3 classes of benzodiazepines. Now, in some cases, yes, it's one doctor. But in a lot of those cases, they're 2 different doctors. And one doctor doesn't know that a prescription was written on February the 1st for 90 of clonazepam for the same patient, February the 3rd for 120, 2 milligram of Xanax. You know, what doctor would do that? Hope, you know, and multiple, yeah. So there are 2, and the 2 doctors don't know it. You see what I'm saying? So we need policies about that, getting this information. And then about prescribing, you know, humongous quantities and so forth.
I believe I was next, right? Just go. Yeah, I know we talked a lot about what the professionals are going to do. I didn't hear a lot about the patients today. I did hear about some responsibility for behaviors. And I also believe that there are a lot of occurring cases out there where people need other medications, including benzos. But we're never, ever going to make any strides until we have some kind of approach towards what they call in the street croakers. The doctors prescribing medications just to make $1. And this is the biggest problem out there. I'm actually in charge of intake where I'm at, and the amount of different drugs that are in the urine screens now is immense. I mean, from buprenorphine to methadone to several different benzos to codeine to, it's just, you know, it's out of hand. And I know there's a big liability on the hands of a doctor. Someone comes in saying, you know, I have this problem, I have anxiety, and you're afraid if the patient leaves, they have a panic attack or they commit suicide. But there has to be some kind of restraint here in order for us to catch a foothold. Without that, we're never going to get anywhere. I mean, there's just too many pills out there on the street, and there's not that many people out there with anxiety problems. I mean, I'm not trying to say, you know, you're already on to said it, but the fact is that we need to get together something to where we're going to not only approach it on the clinical end, but we need to approach this, like you said in your thing, Doctor. There's the legal matter involved here, and there's a lot of legalities involved where people, and a lot of law being broken, where people are just being prescribed because you walk in an office and the doctor takes your blood pressure and feels your hands. It's all right, here goes your 90 Klonopin. See you in 30 days.
Some don't even do that.
I know.
They don't even take the blood.
And that is going to, and that's one of our main obstacles that we really need to make some kind of strides. And I know it's hard, and I know there's a lot of laws and that, but you know, that's one of my main concerns.
Yeah.
Mike, I have a concern on that one thing amongst ourselves. We tell clients to network, but we don't network amongst ourselves. See, the problem that I have is I'll go back to my program, and you're not going to call me, and I'm not going to call you, and we're not going to talk about, I'm not talking about programs, I'm talking about us. There's a learning responsibility and a personal responsibility of ourselves. I'm not waiting for the panel to give me information on benzo. I'm going to get it myself. I'm going to get the state-of-the-art training. I'm going to go south of the border to get it. Because to tell you the honest to God truth, I just went to a CBT class, and there was only 14 people there because they had, the counselors had to pay $80 for the class. They were waiting for the program to give it to them, or it's too much money. So we need to look at ourselves as counselors, because we have personal responsibility to go for state-of-the-art training. And to tell you the honest to God truth, I went for state-of-the-art training, came back to programs, and got killed by the elephants. Because we talk state-of-the-art training, but to tell you the truth, there's none in this state. And you need to get real. We need to look at ourselves, and we need to take personal responsibility as counselors. I'm not waiting for someone to give me information on benzo. There's phenomenal information out there. Why aren't you going to Barnes & Nobles and buying the books on the brain? Why aren't you going to the workshops? Because your agency ain't paying for it? Well, that's all I got to say.
Okay.
Thank you.
All right.
Yes, Taylor. Yes, please.
you were talking about communication and working with each other, as the last few speakers said. My problem came up yesterday. I got a phone call from another agency, but it was just mental health. And they wanted a copy of a drug screen because they don't run drug screens. And when I looked at needless to say, the agency refused to send me a release of information, so they didn't get the drug screen. But when I looked on the drug screen, there were positives for antidepressants and benzodiazepine, and I was just wondering, is there any way that, you know, they can be educated as to what happened here today? Because, you know, when you're depressed, you take A, and when you're, you know, anxious or whatever, you take B, and it just seemed, you know, that they really didn't care what else the client was doing, just that they were keeping their appointments and getting their prescriptions, because they made it sound like if I didn't give them the drug screen, that the client wasn't going to get the prescription. And all I asked for was the release. So, you know, I'm just wondering, is mental health going to be, you know, included in this collaboration? Because you're talking about like primary care. I'm talking about like the doctors that.
No, I agree. That was one of my concerns or areas of focus, is that hopefully today we would have good attendance, or in this process we'd be reaching out to our mental health providers, because many of us have inpatient psychiatric consultation for our patients, but you know, many of our patients see outside psychiatrists in the community health centers and so forth, and you know, many of those patients are getting benzodiazepines prescribed. Patients are telling us that, you know, the doctor is aware and so forth, but often when I contact these doctors, you know, their response to me is, I had no idea this patient was on methadone, you know, despite the patient's telling you. Now, in some cases they do. But again, I agree with that. We need to have our mental health providers in this community and in related communities involved in this process. So I support that.
I'd like to make a comment going back to the issue of the practical guidelines. The points that you made there were really excellent. I've been involved in a lot of the guidelines with the APA, and the biggest challenge is how we going to be able to really use the evidence base. Unfortunately, there is not much in this area, you know, or how can we use more the modified, as Dr. McClellan would say, the evidence-informed. You know, now we try to really start, in the addiction field, we have a lot of gaps in the research in terms of also how to translate the research into clinical practice and how to disseminate that to the treatment practitioners and really to the patients, families. I mean, we have really gaps all over the place. And I think with the practical guidelines, they could really probably draw from whatever the evidence informed and evidence base is there and guide some of the processes in treatment. But I don't believe it's going to replace the clinical judgment and really the practices necessarily significantly what people really do in clinical settings, because there are so many clinical situations that you mentioned. There are so many clinical scenarios that it's just impossible to cover. You know, a lot of things come up really with different clinical scenarios with patients and situations that, you know, we wonder how do we know how to manage this? Do we have any sort of a guideline or any sort of way or any sort of evidence, any scientific evidence on how to really deal with it? And unfortunately, this is the biggest dilemma that we have in the addiction field, that we rely on the science, but the science sometimes really is not enough. It really fails us in a way, and we have to really modify and brainstorm, and particularly engaging, you know, the patient and their significant others in that discussion to come up with some ways that could really work better in some situation that might not really have that evidence base behind it. And this is where basically the biggest really dilemmas that we go through. But I think, and also the one point you made about soliciting a lot of the feedback and a lot of really the suggestions from the people who are on the front line, you know, therapists, physicians, counselors all across, is really getting more feedback from you about really what sort of really challenges and struggles you go through, so we can really take that and really try to see if there is, we can research it, we can do whatever we can to really see if there is any way we can figure out some really practices or some guidelines that could really help really manage these particular situations. But obviously it's not gonna really necessarily replace, good clinical practices. Let's be clear about that.
If it's safe, I think we're getting close to the end of the day. And I first of all want to thank everybody who's participated, both in terms of the panelists and the audience. So please give everybody a big hand. I just want to, and it's a dangerous situation. It's the end of the day, and you're giving somebody who's got 3 generations of Baptist minister a microphone. Let me just say this. Number one, let us not forget that we are in the addiction treatment business. And so that means that we're not just focused in on one drug, but we're working with people. And I'm hoping that these guidelines that we're talking about are reflective of that. We're all coming from a wide array, a great diversity of different areas, places, programs, and we're going to have to bring that diversity to this one table. So that means that we're going to have opportunities to be able to share different approaches to treating a problem. And I agree with the idea that evidence-based practices are important, but also practice-based evidence is important. And so it's important that you all are able to bring that to the table as well. We'll find a way to communicate with you, and I definitely will tell you this. We will keep in touch with you and make you a part of this process, because at the very least, I don't suffer alone. So at this point, I'm going to give it back over to Dawn.
Just a couple more comments. Yeah.
And then we can go from there, okay? Is there a couple more comments?
Just a couple more from me. Some mechanics. Somebody asked about proceedings. It occurred to me, I don't know if I mentioned it at the beginning, but the entire day, as you may have noticed, is being recorded. And those recordings will be available on our website, our iRetta.org website after this, as well as the reference materials and kind of the process of the panel discussion that we've been talking about. If you didn't receive an email from me and you didn't register for this conference electronically, please make sure that I have your email or your business card, or make sure Christine or Jess has that, so that we can have a working list of the attendees from the day, so that we can keep in touch with you and involve you in the process. And please don't forget your evaluation forms. Jess will collect. Thank you so much for coming.